Polycystic ovary syndrome, also known as PCOS. Polycystic ovary syndrome is one of the most common endocrine disturbances affecting women of childbearing age in the United States. A typical patient presentation is a 19-year-old female who presents with late menstruation, weight gain, increasing acne, and hair to the face. She reports her last menstrual cycle was over 2 months ago. She noticed persistent acne and oil on her face, as well as hirsutism in the chin and upper lip area. She has also stated she gained approximately 8 pounds over the last month. She acknowledges she eats a high sugar, high sodium diet. Etiology of PCOS. PCOS is a hormonal disorder that leads to enlarged ovaries with small cysts on the outer edges. Although the cause of polycystic ovary syndrome is not known, like most diseases, it likely involves a combination of genetic and environmental factors. Many of the signs and symptoms are due to unexplained, persistent, hyperandrogenic anovulatory cycles. Let's take a look at the graph to the right. It begins with insulin resistance, which leads to hyperinsulinemia, which branches out furthermore. Let's begin on the left with decreased hepatic production of SHBG. SHBG is a sex hormone binding globulin, and that can stem to hyperandrogenism, which that can stem to either ovulovulation and anovulation and PCOS. Eventually, they'll both lead to PCOS. And after hyperinsulinemia can also branch out to abnormal folliculogenesis. Folliculogenesis is the maturation of the ovarian follicle, and that will lead to high estrogen and high testosterone, which also leads to hyperandrogenism, which will also stem to the same two, ovulovulation and anovulation, which both lead to PCOS. The third factor, elevated LH. LH stands for luteinizing hormone. A luteinizing hormone is the hormone produced by gonadotropic cells, and it triggers ovulation. And that will lead to ovulation and ovulation, which will lead to PCOS. Background of PCOS. PCOS is a common endocrine condition. It's associated with hyperandrogenism, as we saw in our previous slide, infertility, and metabolic dysfunction. PCOS is the most common cause of female infertility. About 1 in 10 women in the US are affected with PCOS, and it's affecting 6 to 12% of US women of reproductive age. Risk factors of PCOS. PCOS will affect women of childbearing age. PCOS will also affect women who lead obesity-prone or sedentary lifestyles. Obesity-prone lifestyle also goes hand in hand with insulin resistance. Another risk factor is genetics. This can also be passed down. Patients with PCOS have an increased risk of the following: diabetes, and then if the woman is able to conceive while she is pregnant, gestational diabetes, heart disease, high blood pressure, sleep apnea, and even stroke. The pathophysiology of PCOS. In the next few slides, I will go into greater detail of these categories. Hyperandrogenism. hyperinsulinemia, neuroendocrine abnormalities, polycystic ovaries, and long-term morbidity. And to the right, I've attached a PCOS phenotype bubble and all the factors affecting it. Some are exercise and activity, genetic variants, diet, ovarian factors, adrenal factors, insulin sensitivity, and CNS programming. Let's begin with polycystic ovaries. Polycystic ovaries do not have to be present to diagnose PCOS, and their presence alone does not establish the diagnosis. But 20 to 30% of women with PCOS have cysts on ovaries detected through an ultrasound. Although these are not actual cysts, they're antral follicles. The long-term morbidity of PCOS. First, subfertility, which is a delay in conception. If you are able to conceive, a miscarriage, spontaneous loss of a pregnancy, cardiovascular disease, type 2 diabetes, psychiatric disorder, anxiety, depression, and binge eating disorder. Hyperandrogenism, which is high levels of androgens. Hyperandrogenism is the most characteristic feature of PCOS. The consequences of hyperandrogenism are obesity, hypertension, amenorrhea, and ovulatory dysfunction, which can lead to infertility. Hyperinsulinemia is the excess levels of insulin circulating in the blood, which is often caused by insulin resistance. Neuroendocrine abnormalities. Increasing frequency of gonadotropin-releasing hormone. Inappropriate gonadotropin secretion triggers the beginning of a vicious cycle that perpetuates anovulation. The production of the luteinizing hormone and the decrease of production of follicle stimulation hormone. The follicle stimulating hormone is a hormone that helps control the menstrual cycle and stimulates the growth of eggs and ovaries. So a decrease in this would be very bad. Please take a moment to pause the video here and look at this mapped out pathophysiology of PCOS. Symptoms of PCOS. First, dysfunctional uterine bleeding, hirsutism, acne, subfertility, or in severe cases, infertility, hypertension, dyslipidemia, irregular menstrual patterns, and obesity. The diagnosis of PCOS. As I stated before, polycystic ovaries are not a necessary to diagnose PCOS. In order to have a diagnosis for PCOS, there must be evidence of androgen excess, chronic anovulation, insulin resistance, and inappropriate gonadotropin secretion. Here are some treatments for PCOS. The first, a combination of oral contraceptives, and the most popular is birth control. This is used to control irregular menstrual cycles and to oppose estrogens and androgens. Next, insulin sensitizers like metformin. Metformin may be used to decrease insulin resistance, prevent diabetes and heart disease, and restore fertility. And reduction in weight, which is the most effective in treating PCOS. It can dramatically improve insulin sensitivity and return of ovulatory cycles. And here are my references if anybody would like to look more into polycystic ovarian syndrome.